to the last session of the meeting. This session is going to be on the management of deep endometriosis of the sacral plexus.
Thank you very much for inviting me to speak. It's been one of the best conferences I've ever been to. I think I can say that with confidence. And I want to also thank Horace for putting up with me, because I was one of those annoying invited speakers that you ask them to talk about something and he emails and says, but can I talk about something else? You know, don't do that. That's very annoying.
I'll talk a little bit about symptoms. I ended up with the preoperative assessment of, I've written here sacral nerves, but it will be nerves in the pelvis.
Good afternoon, and I'm very honored to be here, especially in this session. I must admit that when my friend Horace asked me to have this presentation with this title, I made him a question: why nerve sparing in a session of sacral roots and sacral nerves?
The discussion that I'm now at the tail end to talk on neuropraxia and what it actually means.
My name is Horace Roman. I come from Aarhus University Hospital. We're going to speak about outcomes. This is my university, and I have no disclosures.
Our next speaker will be Dr. Horace Roman, our president. We'd like to thank him for all that he has done to put this wonderful meeting together before we begin his presentation.
Thank you very much. I tried to build an interesting program, but I forgot that it is very difficult to speak after Marcello Ceccaroni. So I missed this. I forgot this. So I will try to start by telling you the same statement I told you this afternoon. So if you think that this surgery is interesting, the best way to start to do it is to attend the courses of the International School of Anatomic Surgery, which the director is Marcello Ceccaroni. So I strongly invite you to pay attention to these courses. So now let's speak about the excision of deep endometriosis of parametrium, and to try to identify the steps, because I think that the objective of my presentation is to try to standardize the excision of deep endometriosis nodule, which involve the parametrium, down to sacral roots, in order to be able to teach them. Because teaching advanced surgical technique in endometriosis is a very challenging task. So we have fellows, we have residents, and ask us how to do this kind of surgery, because it's so different from a patient to another one. It is true, but if you have a look at what experienced surgeons do, you will see that they follow, some voluntarily or not, they follow the same steps which are responsible for safety, for exposure. So I think that now it is much easier to learn the surgery, since we have the laparoscope, since we have we can broadcast the surgery, we can record the surgery, we can put our surgeries on social media, so it's much easier to become a good surgeon now than 20 years ago. But we also have to provide some steps, mandatory steps, to be followed in order to make these procedures logical and reproducible. So the step-by-step approach means to try to identify successive logical stages which should be followed, with the goal to perform the excision, of course, because the first goal of the surgery, but also to avoid some risky situations or circumstances which may be responsible for intraoperative major complications, but also to avoid some procedures, some situations which may be responsible for postoperative complications and a loss of the good results of the surgery. And now we have more and more video articles or studies which try to identify 10 steps procedures. And if you look at the PubMed, you can find 12 articles with the keyword 10 steps and endometriosis surgery. So the goal is to try to identify 10 steps procedure in the approach on sacral plexus and sciatic nerve. So this surgery, it has been emphasized by Marcello. It's a surgery of the parametrium. And the parametrium is an anatomical area, which is delimited medially by the rectum, the vagina, and the bladder, and laterally by the pelvic wall and the sacrum. And in this area, we will find a myriad of nerves, but also some major vessels and the ureter. The nerves may be somatic and may be vegetative. So here you have a presentation of the most important nerve we can find in the parametrium. But we have to emphasize that when you speak about nerves, pelvic nerves, we have to identify two types of nerves. We have the large diameter nerve. So Shahin said that the sciatic nerve is like the thumb, but there are also the obturatory nerve, the sacral roots, the pudendal nerve. So these nerves can be seen. You saw yesterday during the live surgery, I saw clearly the obturator nerve. These nerves should not be sectioned or injured because they are somatic, so their injury may be followed by anesthesia or motor palsy, which is dramatic. And then we have the thin nerves, the superior, the inferior hypogastric plexus, the hypogastric nerves, the splanchnic nerves. These nerves are thin, they are vegetative, but they may be very difficult to identify in deep nodules of the parametrium because they may be involved, may be inside the fibrous tissue, and also in frozen pelvis. So the nerve sparing specifically refer to these thin nerves when they are not involved, as it has been very clearly emphasized, and their injury led to vegetative functions which may be very, very embarrassing on the long run. We also may have two types of nodules, deep endometriosis nodules of the parametrium. The nodules I call type 1, or the big nodules of the parametrium, which may involve not only the parametrium, but also the rectum, the vagina, the ureter. These nodules usually come on contact with the sacral roots, S3, S4, sometimes S2. So the symptomatology is in majority based on function of the bladder, alteration of the function of the bladder, vaginal dryness, constipation, and as Mikkel emphasized, there is no symptomatology of the leg. Here I pick up a picture from a presentation of Christelle. She sits right there. So it is an anatomical preparation of a cadaver, and you see here in yellow very well the vegetative nerves, the superior hypogastric plexus, the inferior hypogastric plexus. You see the splanchnic nerves coming from the sacral plexus, and you see the vein and the hypogastric artery and vein and the external artery and vein. And you see also the rectum, the vagina, and the bladder. The type 1 nodule are placed like this. So they involve the inferior hypogastric plexus, the splanchnic nerves, and S3, S4. The second type of nodule, I call them type 2, or more lateral. They are in contact with the sciatic nerve, the pudendal nerve, the obturatory nerves. They are less frequent. They represent, in my experience, 15% of the nodule of the parametrium. And they are lateral, so usually they do not reach the rectum or the vagina, but they can be responsible from stenosis of the ureter, which is much closer. So these nodules are responsible from symptoms from the leg, the palsies, shown by my colleagues, and also from pain into the buttock, into the leg, and into the perineum. Now, let's come to the cadaver and to see where the type 2 nodules are placed much more laterally. So the surgery is not the same, the steps cannot be the same because the two nodules are so different. Now, we'll go to the 10 steps procedure. You have to know that they were presented in two video articles. They are in open access, so there's no need to pay attention too much to the videos because you can see them this evening for free. The first video referred to the surgery of the type 1 nodules, so the big nodules of the parametrium involving the sacral roots. And here I identified 10 steps I always follow during this surgery. And these steps may be separated in safety steps. So I do them in order to prevent ureteral or vascular injuries. So I start by performing ureterolysis. I also dissect anterogradially the hypogastric artery, the hypogastric vein. I ligate some veins going into the nodule in order to avoid to blast them, to injure them when I turn around the nodule. So they are safety steps. Then I identify 5 dissection steps. So they are the steps who try to identify the thin nerves, try to preserve them, to identify the rectum, to try to preserve them, or to simply separate the nodule in a part into the rectum, which will be removed at the end of the procedure. Identification of hypogastric nerves, identification of superior hypogastric plexus, and beginning of the dissection of the hypogastric vessels. And then there is a last step of dissection, which is the identification and the dissection of the sacral roots itself. Once we could go behind or underneath the venous plexus and in the front of the piriform muscle, as it has been shown by Shaheen. And then the last 2 steps, or excision, represent the excision itself. So it may require a shaving or the neurolysis, as it has been shown by Marcello Ceccaroni, and the complete excision of the nodule by turning around and releasing the muscles and the other structures. So these are the 10 steps I always systematically, mandatorily follow during the removal of these large nodules. Of course, the surgery is not finished with these steps because there is also the infiltration of the vagina, of the rectum. That's why I agreed with Mikkel. Mikkel told me 2 days ago, I think the surgery of the type 1 nodule is much more difficult than the second one. I completely agree with him. The operative time is longer because there are procedures on the rectum in 86% of cases, on the urinary tract in 46% of cases, and cumulating this surgical steps, of course, we have procedures as long as 3 hours and a half or 4 hours. Now, let's go to the second type of nodule, the nodule involving the sciatic nerve, the obturatory nerve, the pudendal nerve, which are much more lateral. So here we can identify 10 steps. 6 steps or safety steps. So we are on contact with the external iliac vessel, the external iliac vein. We are on contact with the obturatory vessels. We have the obturatory nerve. So these steps try to avoid injury of vessels and or large nerves, because I told you injuring the large nerves may be dramatic in terms of outcomes. So there is the dissection, lateral dissection, and then medial dissection. So I start the dissection laterally from the external iliac artery and vein, but then I come back medially, and the majority of the procedure is done medially from the external iliac vessel. That's why Marcos Ballester asked me recently if it is mandatory to do the 4 first steps, because I do not use it too much in the excision. It may be necessary to sacrifice the obturatory vessels in order to avoid a hemorrhage. And then we have 4 steps of excision itself. Usually I start at the posterior limit of the nodule because it's more logical. Then identifying of the S1, S2, S3 of the pudendal nerve and the releasing of the posterior medial limit of the nodule. Then the lateral dissection on contact with the bone, with the ischium and the sciatic spine. And once the nodule was released posterior, medially, and laterally, we can go anteriorly, and there we may see there is an infiltration of the bladder, and we finish by excising this infiltration. So in majority of time, the surgery is on contact with the obturatory nerve, so the instruments touch continuously the obturatory nerve, and it is not rare that the patient has some palsy of the adductors for 2 or 3 days after the surgery, but usually it restores very well. I cannot stop without speaking about the robotic assistance, because now I do all the surgery with the robotic assistance. I think there is a huge advantage due to the sharp to the miniaturized instruments with a high mobility, to the access of the small deep spaces with a camera which does not move and which can be flipped up and down 30 degrees. So I strongly advised all the colleagues who have a robot to try to do this surgery robotically, and I think you won't come back in laparoscopy even though you do it very, very well laparoscopically. So in conclusion, demonstrating the surgery does not mean teaching it, because the people who look at you won't be able to do it once they get back home. So I think that if you want to teach a procedure, we try to identify specific steps to follow. I think about the Negrar procedure. It is a perfect example to steps to follow in order to do the surgery completely. That's why I think this 10-step procedure model is a very useful tool to improve the surgical learning. It looks like a navigation plan. It is impossible. Nicolas Bourdelle told me when he told several times when he prepared the presentation about the augmented reality that it is impossible to think that a driver take the car and go somewhere without knowing the way to follow, or the same for a plane. So why the surgeon should not have steps, very well identified steps, particularly in very complex procedures. I think the 10 steps procedure model avoids intraoperative vessel and nerve injury, but also allows the control of the hemorrhage when it occurs. Because once you dissected your, you previously dissected your hypogastric vein, it is easy to clip it. Conversely, if you go directly on the nodule and you injure a deep vein, it is very, very difficult to control it. And then at the end, it enables the complete excision of deep endometriosis, and also allows the training and exchange between fellows and colleagues, because we know what we're talking about. So my take-home message is try in your surgery to try to standardize your procedure using these 10 steps, and I cannot finish without special thanks to Nicolas Bourdelle, who was the first to share with me the idea of 10-step methods, and he invited me to try to standardize my procedures, disc excision and anything else. By the way, Nicolas Bourdelle is the godfather of Violette, and we share not only good moments in surgery, but also in our family life. So thank you very much. Thank you for being here in Bordeaux. because this Congress was successful simply because you are here. Thank you very much.
Maybe we have one or two questions. Yes.
This type 1 and type 2 patients, which patient are suffering more? Actually, clinically, like I want to know in.
But it depends, because when you see the movies shown by Shaheen and Mikkel with patients with palsy of the leg, you can think that they are in a big trouble. But also the patients with nodule, type 1 nodule, with bladder dysfunction, with severe dyschezia and the impossibility to have sexual intercourse and pain into the perineum, it may be. I remember a patient where he come with very, very painful situation, and the anesthesiologist had to put an epidural anesthesia to understand what's happened, and it was a huge pudendal pain. It was a patient I managed in live surgery for Koshi 5 years ago. So this patient had unbearable, it was unbearable, the pain.
Means I wanted to know in relation whether small nerve disease affects more or the thick nerves get affected, the symptoms are more.
There are different symptoms, but the intensity may be huge on both sides, I think. What do you think? The symptoms are different, but they may be very, very difficult to bear.
Thank you.